Part 3, Chapter 42, Diseases of the GI Tract. I'd like to thank Elsevier and McCann's book on pathophysiology. So inflammatory bowel disease is a big problem in our society. Chronic relapsing inflammatory bowel disease, unknown origins, genetics, environment. For examples are ulcerative colitis of Crohn's disease, which are full of it. Ulcerative colitis is a chronic inflammatory disease caused by ulceration of chronic mucosa, sigmoid rectum particularly. It's common in those 20 to 40 years of age. Pathophysiology is lesions and continuous, no skip lesions, limited to the mucosa, and they are not. This is what ulcerative colitis looks like in a specimen removed. You can see that this is quite extraordinarily inflamed, and you can imagine trying to live with this, trying to pass stools with that. Clinical manifestations: large volume of water, diarrhea, bloody stools, cramping, urge to defecate, remission, and exacerbation. First-line therapy is mescazoline, steroids, salicylics, immunosuppressive agents, broad-spectrum antibiotics, surgery, resection of colon. Immunosuppressive agents are more common today now. You hear commercials on TV for all of them all the time. There are new ones coming out all the time, trying to stop the inflammation. There's an increased risk for colon cancer is demonstrated significantly. Crohn's disease is a granulomatous colitis or ileocolitis or regional enteritis. Is idiopathic inflammatory disorder, affects any part of the digestive tract from mouth to anus. Difficult to differentiate from ulcerative colitis. Similar risk factors and theories of causation. Strong association with particular genetic mutations. Causes skip lesions, not continuous, inflamed areas mixed with uninflamed areas. Non-caseous granulomas, those are granulomas disease, which we talked about in immunology. Fistulas, deep penetrating ulcers, can be quite sick. They have rectal bleeding, diarrhea. Most common signs of abdominal tenderness because of the fistulas. Anemia may result in malabsorption of B12 and folic acid. Treatment similar to ulcerative colitis, immunosuppressive agents, tumor necrosis agents to block and treat fistulas. Surgery, complicated short bowel syndrome, malabsorption is very difficult to manage. So this is the appearance of a normal colon being in a normal versus a Crohn's disease, and this would be normal, and as the Crohn's disease A is abnormal cobblestone appearance, the hyper, and this is how the normal colon look smooth, regular. This is how Crohn's look. Features of Crohn's: locations, lesions, colon, rectum, ulcers, ulcerative colitis, the GI tract from mouth to anus. Affected areas: mucosal, entire intestinal wall, granulomas are rare, cobblestone appearance, abdominal pain, occasional, common, bloody stool, less common, sternuria, rare, common. So some of these other things you'll never run. And this is some pictures of the different effects of the disease on different parts of the finding is typical of Crohn's disease, like caseous and granulomas, continued primary with no skip lesions, prone to develop Cushing ulcers, intermittent gets the pain with stomach empty. So it's a continuous primary lesion with no skip lesion. No, that's not true, right? So non-caseous and granulomas, which we mentioned. Irritable bowel syndrome is a functional gastrointestinal with no specific structural biochemical alteration. In pathophysiology is visceral hypersensitivity and hyperalgesia, abnormal gastrointestinal permeability, motility, pro-inflammatory irritable bowel syndrome, food allergy, food intolerance, and there's some psychological factors. Clinical manifestations are lower abdominal pain, diarrhea, predominant constipation, predominant alternating diarrhea, constipation, gas, bloating, and noise. This is really presents this alternation of diarrhea and constipation, gas, bloating, and nausea. Difficult to manage. Treatment is no available cure. Laxatives, soluble fiber, restrict gluten, possibly. A lot of times people go on gluten-restricted diets, not because they have gluten, but because they have irritable bowel syndrome. Antidiarrheals, antispasmodics, pro-secretory drugs, visceral analgesics, and low-dose antidepressants and SRAs and antibiotics. Diseases of the colon, they have diverticular herniation of the mucosal through the muscular wall of the colon wall. Diverticulitis is the asymptomatic diverticular disease. Diverticulosis is the asymptomatic diverticulitis is the inflammatory stage of the disease. And predisposing factors, older age, genetic obesity, smoking. Older age is probably the most prominent thing because elderly people frequently get a colonoscopy on them as soon as they're in their 50s and 60s. You're going to see some diverticular disease in the reports. If it doesn't bother them, you don't have to worry about it. This is these pouches that develop in between the normal lumen of the intestine. Clinical manifestations of cramping, abdominal pain, diarrhea, constipation, distension, flatulence. Diverticulitis has fever, it looks like that. Treatment of dietary diet, complicated by bowel rest. Sometimes you have to give them antibiotics, and surgical resection may be required depending on the severity of the diverticulitis. All food and everything that passes through there, fecal matter, can get caught in there, and this is what they think causes. Inflammation of the appendix is biform appendix with possible causes of obstruction, ischemia, increased intramural pressures, infection, inflammation. Clinical manifestations, epigastric pain, rebound tenderness, nausea, vomiting, antibiotics, and appendectomy. Right now, we treat most acute appendix. Usually get a course of antibiotics to see if they can ride it out without having surgery. Obviously, if it's perforated or symptom of perforation, then you have to have surgery. Clinical signs and symptoms increase with WBC, abdominal sonogram, respiratory lap, rebound tenderness, pain, right upper arm. Take it easy and calm down. But then this is abdominal pain, fever, bloody diarrhea, hypovolemia, lactose, leukocytosis, and shock. Treatment, antibiotics, anticoagulation, vasodilatation, rehydration, and surgery. Portal hypertension, abnormal blood pressure in the portal venous system, primarily caused by resistance of portal blood flow. Increased to above 5 millimeters of mercury, normally is 3 to 5. Causes pre-hepatic, intrahepatic, and post-hepatic. Can cause fatal consequences. Pre-hepatic is obstruction, intrahepatic is obstruction, and post-hepatic is after. Consequences, varices, so the blood backs up in the system, the distended tortuous collateral veins, esophagus, stomach, rectum, and then the spleen becomes enlarged because the spleen drains this way through the liver, and you can get thrombocytopenia this way. So just to finish up on portal hypertension, you can have hepatopulmonary syndrome, respiratory complications. So this is the clinical manifestations, again, of portal hypertension, and usually requires endoscopic venous ligation, surgery. This is a picture. This is as the portal system backs up, you get hemorrhoids, varices, you can get splenic varices, you can get esophageal varices, and all caused by back pressure. And be associated with portal hypertension and liver disease. The overflow theory, renal sodium retention causes intravascular hypovolemia. Underflow theory, hepatic sinus, hydrostatic pressure, and peripheral arterial theory. I don't think any of you know that. Ascites accumulate from the peritoneal cavity, most commonly caused by cirrhosis, but also from cancer. This is a cartoon to try to You can see the increase of capillary fill pressure, and then you have transudate plasma into the peritoneal cavity. This is what it looks like. This is the belly button, the umbilicus being pushed out by the pressure within. This person could have 5 or 10 liters of fluid in there. Treatment: dietary salt restriction, potassium sparing diuretics, stronger dish of furosemide with uric acid if necessary, vasopressin receptors. Treatment for the typical treatment for ascites is paracentesis, and you see it's 1 to 2 liters. That's going to stand the thing, but relief of respiratory distress. In oncology, the depiction that you saw previously is not 1 or 2 liters of fluid. This is probably 5 or 6 or 7 liters of fluid. But if you remove too much fluid too fast, relieve the pressure, the blood vessel causes arterial vasodilatation, carries the risk of hypotension and shock. If you do it slowly, you can pretty much take off as much as you want. You just have to be careful. Acidic fluid accumulates in an individual with irreversible disease is likely to cause peritoneal peritonitis. Transjugular hepatic stent is a possibility.